Okay, so I think we'll do you want to get started, Julie, or just wait for a couple of moments as people begin to join? Maybe we'll get started and then people can join as they will. My name is Marcia Campbell-Yo. I'm the acting director for the center, and it's my pleasure today to share this webinar. Before we get started, I think it's very important for us all to take a moment, regardless of where we're joining from today, to consider the land in which we are joining from, and certainly from Dalhousie and in my home nearby. It is seated in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq peoples, and I think it's important for us all to take time to reflect on that always before we begin to share our information and to consider, of course, we are all treaty people. So having said that, again, from wherever you're joining, it is my great pleasure to have today and introduce Dr. Jennifer Isenor, who's Associate Professor at Dalhousie University, as well as Dr. Amy Grant, who is a Senior Health Policy Researcher from MSSU, and they're talking. And they're talking with us today around the uptake of pharmacist prescribing in Nova Scotia and analysis of self-report and administrative health data. And just really looking forward to hearing this. So welcome.
Thank you very much. We're very pleased to be invited or welcome to speak today about our project. So I'm going to get us started. And so I do want to acknowledge our very large team, which has made this possible. So you can see we have representation from the Nova Scotia College of Pharmacists, the Pharmacy Association of Nova Scotia Health, many academic partners, Health Data Nova Scotia, and we would not have ever been able to do this without MSSU. So they're obviously a partner, but I'm super thankful for everything they've allowed us to do with this project. So the project started, there was a lot of thought around the role pharmacists could be taking within primary care and improving access to prescription medications. So with changes in scope of practice and primary healthcare access, this was identified as a provincial priority area at the MSSU Nova Scotia Bridge event in November 2018. And so we then formed that very large interdisciplinary team and started working on the project. And so just a little more background on pharmacist scope of practice. So we really did focus on prescribing with this study, which originally started around 2011. It was approved by the Nova Scotia College of Pharmacists, and it was for assessment of prescribing. And then it's been evolving and expanding ever since. And most recently, there was some additions for the prescribing of shingles and complicated cystitis and contraception, and expansion of how long renewals could be. And this has been in the last couple of years, but you can see the list in the box there of the different prescribing categories. So there are approved conditions, emergencies, renewals, adaptations, substitutions, and then just other drugs that are non-prescription, but either pharmacy sale only or behind the counter sale. And so they're not all funded, and I will mention as we look at some aspects of the results we found. So there has been a number of studies internationally around the role of pharmacists prescribing. So pharmacists are authorized to assess to prescribe, so it may not result in a prescribed medication, but we'll refer to it in general as prescribing. And various studies have found there was increased patient access and satisfaction of patients with care. There was more appropriate referrals when necessary, improved medication adherence and symptom resolution, and potential cost savings to the healthcare system. But unfortunately, uptake has been lower than expected in most jurisdictions. And for Nova Scotia, for those of you in Nova Scotia with us, you probably know that we have issues with primary healthcare access. And in 2018, there was about 45,000 people on the wait list. And we have the latest report from February 1st, and we're up to 133,595, which is about 13.5% of the population. So people needing primary care access has been increasing. And so there's a lot of interest in the potential role pharmacists can take in helping remove some of those access barriers, at least related to medication access. So we wanted to look further into this. And so we are using, or we've used a two parallel approach, and both studies have been published now, just one of them very recently. It's showing as a March 2023 publication date. So it's our preprint or our online access in advance. So one part of the study was to do a mixed method survey of pharmacists in Nova Scotia to determine the extent of self-reported prescribing activities. And we did have to take a pivot with COVID. So we were going to release the survey in early 2020. And then, of course, the pandemic was declared. So it was delayed. So we were able to pivot and ask about changes related to the pandemic as well. And we were looking to identify perceived barriers and facilitators to the pharmacist around their prescribing. And then with our administrative data analysis, we were looking at frequency and type of community pharmacist prescribing over time, and the characteristics of the patients who are using pharmacist prescribing services. So we developed our survey using a previously validated survey that members of the team had used in 2014. And we used the theoretical domains framework version 2 to study this. And we adapted again to include COVID-19 related questions. And we distributed the survey online through the Nova Scotia College of Pharmacists to all pharmacists that were licensed to practice with a direct patient care license. So to try to target the pharmacists who were most likely prescribing. Well, the only ones who could prescribe because they're licensed to prescribe. These are the 14 domains of theoretical domains framework with just brief descriptions, but you can see there's things around knowledge and skills, intentions, goals, a variety of aspects of behavior change. And then here's just a couple of images from the survey. So the one on the left is we asked to the best of your recollection in a typical month, how often did you prescribe? So this was again self-reported, and we asked prior to COVID-19 starting, so before March 2020, and then since March 2020. So we really did want to capture if there were perceived changes in how often they were prescribing. And then below and on the right here, that's the an example of a couple of questions that were related to the theoretical domains framework, or the TDF. So there's some knowledge questions and some skills questions there as examples, and we used Likert scales for those questions. So for analyzing the Likert scale responses, we did convert them to numerical scales from strongly disagree to strongly agree. And then we did collapse them for reporting purposes into negative, neutral, and positive. We also identified high and low frequency prescribers, which we did based iteratively on the data because there aren't definitions in the literature around what makes somebody a high or low frequency prescriber, but based on what we were seeing in the data and what seemed reasonable based on the literature we could find as well as our own experience. Low was 0 to 14 times per month, and high was 15 plus times per month. And we also had some open-ended questions related to further barriers, which we analyzed using the TDF as well. So we ended up with 190 responses, which represents about 14.2% of the direct patient care community pharmacists in Nova Scotia. The survey was open in July to October of 2020. And we did end up having a limited response to our demographic questions, but for the responses we did receive, they did align quite well with the CIHI workforce data. So gender self-identification resulted in equal split between those identifying as men or women. The average age was 45.7, average experience was just over 20 years. And there was a mix of pharmacy settings with 37% identifying as working in rural areas. So for prescribing patterns, we really did see a big increase in self-reported prescribing activities compared to the original survey in 2014. At that time, we did see 77% said they prescribed at least once per month, whereas in this survey, we saw 98%. And the frequency really increased when we compare to the past, but also when we compare pre-COVID to since COVID. So you can see in the top right, the high frequency prescribers. There's more people that would report as high frequency prescribers since the pandemic started compared to prior. We also saw more prescribing activities covered by government funding. So the government of Nova Scotia had opened up some funding in January of 2020. And some of that then increased again in March of 2020. So it's not surprising that we are seeing that there was more prescribing for funded services because more funded services became available. But this aligns with when we look at some of the barriers that people have reported as well. And we did see some changes in the prescribing categories that were more common. So renewals was most common. And that again became a funded service in March of 2020. And then we did see some changes for which types of conditions were being funded or prescribed for. In some, there was a decrease, such as prescribing an emergency. So this next image I'm going to show you is very confusing to look at probably on your screen. It's really just reiterating some of what I just said about the prescribing categories. So renewals did see the most frequent activity of more than 30 times a month. So that's that top bar there. And that's during the pandemic from the before rate, which was not as high. And then the lowest things we saw were diagnosis from another primary care provider or prescribing an emergency. So that's just more of an FYI to show you a little bit more of the data, the granular data. So when we looked a little bit more into their self-reported prescribing as well, we saw the conditions prescribed most frequently pre-pandemic were herpes simplex virus, so cold sores, uncomplicated cystitis or bladder infections, and travel vaccines. And we did see a shift once the pandemic started. So uncomplicated cystitis became the number one, with contraceptive management and herpes simplex coming in as second and third. So when we looked into the top facilitators and barriers, so again, we used the TDF and that Likert scale around positivity and negativity. And for facilitators, we found knowledge was one of the strongest facilitators, as well as reinforcement. And this was positive reinforcement. So those positive outcomes for patients, as well as social professional role and identity. So feeling that this was really part of their professional role was seen as a facilitator. Some of the barriers were a lack of supports for pharmacist prescribing, so feedback on the prescribing or support systems, which falls within the category of behavioral regulation within the TDF. A lack of clear plans to incorporate prescribing into practice or goals was seen as a negative. And then there were potential negative consequences and concerns around patient outcomes and the time it takes to actually provide that proper care to a patient. So those were beliefs about consequences for the TDF. A few additional barriers that didn't necessarily align directly with a tagged domain around lack of staff and challenges integrating prescribing into overloaded workflows. Actually, these do tie into domains. Sorry, they just didn't tie into our top three, but they were identified so frequently that we wanted to mention them. So just some additional. So lack of staff and challenges, again, with the workflow. A lack of appropriate reimbursement. And it wasn't clear if this was for pharmacists or pharmacies in general. And this again came back to that. A lot of services are not funded. So a patient would have to pay out of pocket if they received a service from a pharmacist, but it might be covered by another provider. So there was concerns around that. And having to ask patients to pay for prescribing services not covered by the government. So many were identifying that they wouldn't offer a service if it wasn't covered because they didn't want to have to ask a patient to pay for something. So when we dove into the qualitative responses to those open-ended questions related to barriers, we found that 100 out of 190 of the respondents actually wrote in at least one open-ended response. And the top three domains we coded were environmental context and resources. So tying into that other barrier I mentioned before, that lack of staff, and that really tied into that workflow and time. Reinforcement, and this was negative reinforcement. So there was a positive reinforcement of good patient outcomes, but on the other side, there was that concern around negative reinforcement of a lack of reimbursement and having to ask people for funding to pay for a service and not wanting to do that. And again, tied to that is that social influence of patients having to pay for a prescription. And we have some sample quotes here as well about lack of staffing and the reimbursement. And some concerns initially about the media saying what a pharmacist could do, but then people expecting a service that maybe was beyond the scope, or wanting it immediately and not wanting to wait at all, and things like that. So we have a lot of rich data on the experiences of the pharmacists, especially during that early part of the pandemic. And we also completed a series of simple logistic regressions to evaluate the association between, or the TDF domain reporting, so the positivity or negativity on the TDF domain, to the actual frequency of prescribing, and that was self-reported prescribing. And we found the three largest influences, so that were associated with increased prescribing, were consequences, so the positive consequences, those beliefs about consequences of positive results for patients, social influences, and this was having peers and colleagues that were supportive of their prescribing. So there were specific questions related to that. And intentions. So those who intended to prescribe were more likely to prescribe. And now I'm going to hand it over to Amy, who's going to talk about all of our administrative data results.
Thanks, Jen. Excuse me. So yes, you can jump to the next slide, Jen. We'll keep you on the slide share. Perfect, thanks. So yeah, kind of a funny breaking point because we talked about the first part of the study. Now I'm going to jump into the administrative data, and then we'll kind of give a summary of what we've learned from these two separate studies that we conducted. So as Jen discussed at the beginning of the presentation, we also had a second part of the study which looked at administrative data. So the first part focused on self-reported prescribing by pharmacists through the survey. And this looked at administrative data housed at Health Data Nova Scotia. So the data that we're primarily focusing on is from the Drug Information System. And so this is a record of prescriptions, of medications prescribed for patients in the province by any provider, but we focused on medications that were prescribed by a pharmacist specifically. So at the time of the study, when we first started the study at least, the DIS, as I'll refer to it as, was a new database that was now available at HDNS. And so we kind of had one of the first big dives, I guess, into this data, and many lessons learned from that. So the focus was really on two parts. One was looking at pharmacists. So we have a cohort of pharmacists who prescribed. So we're able to look at, or intended to look at things like amount, types of medications prescribed, and the characteristics of the pharmacists who were prescribing. And then we also had a patient cohort. So not only the pharmacists who were prescribing, but the patients that were receiving medications prescribed by a pharmacist. And we were also able to look at things like demographic, socioeconomic, and health utilization indicators. So I also listed the other databases on that slide if you're interested, and in those, but really we'll be talking about the data as a whole and the different areas of focus. And then the other piece that's, I think, important as well as we talk about this is the study period. So the entire study period, we had data access from October 2016, which is the earliest data available in the DIS through HDNS, and then at the time of the study up until March 31st, 2020. And so it kind of ends right as the pandemic began, whereas the self-reported data, we were able to extend that a little bit, or had to extend that a little bit because of COVID. And then there's follow-up work being done to look at prescribing beyond that point of time. So the outcomes assessed. So one of the things that we learned, we intended to look at different types of prescribing through the DIS, but we learned that the quality of the data was not actually able to really tell us what different types of prescribing were happening. So what we're able to say is any prescribing that's happening by a pharmacist. And these are the different types of prescribing that would include. So Jen also talked about this a little bit in the beginning of the survey results around the different types of prescribing that are happening. So things like renewals, adaptations, substitutions, prescribing in an emergency, again, something that wasn't super common in the self-reported data. So any type of prescribing that we talk about is kind of what we name first fills. And it can include any of those categories, but we weren't able to break it up into those individual categories. So this would also include prescribing for common and minor ailments, again, which we talked about a little bit in the first part of the survey results as well. And then the third piece is around the characteristics of patients who receive prescribing. Thanks, Jen. So again, we have these kind of two areas of focus, the pharmacist cohort and the patient cohort. Stats aren't always the most exciting thing to talk about, but just to have an overview for those of you who are interested, we report both descriptive statistics in the following results, and then we were also able to compare through ANOVAs or regressions the change or the difference in the amount of prescribing that was happening over time, or in the amount of prescribing that different patient groups received, and then to look at what patient characteristics were associated with prescribing more by a pharmacist. Slide. So the results, the exciting part. So this kind of aligns with the self-report data if you think about the kind of overall pattern that we see. So more or less what we found was in year 3, so that 2019 to early 2020 period, prescribing on average by a pharmacist was higher than in the first or second year of the study. So in that 2018 fiscal year, so 2018 to 2019, was about 24.6 first fills, as we call them, per month, and then up to 32.5 in that last fiscal year of the study. So really, we can see that pattern is that there is more prescribing happening over time. And with this ending right before the pandemic, thinking about how this might look now, we can also expect that I would expect that it is much higher based on what pharmacists self-reported in the data in terms of how much more prescribing they have done since COVID began. And then in terms of the types of prescribing that were happening, what we did was we actually identified those top 10 categories from the survey results because we had that data first. And we were able to look at how much prescribing was happening for those top 10 conditions that were self-reported through the administrative health data. So we see some kind of similar things. So if you remember from that slide where Jen highlighted the top 3, travel vaccines were very common pre-COVID, which this data goes up until. Contraceptive management, which again became even more common since COVID began, and prescribing for GERD, herpes zoster, again, I think that was the first top category in the pre-COVID period. So we see some similar patterns here, but this gives you an idea of the volume of prescribing that's happening. So over the entire study period, so 2018 or 2016 to 2020, this is the total volume of prescriptions for medications prescribed by pharmacists over that period. And then we also have highlighted there what services had government funding beginning in January 1st, 2020, which were also highlighted earlier, but just as kind of a point of comparison, this gives us some baseline data to look at to see whether those services that are funded by the government, if there's more medications prescribed by pharmacists for those services over time based on this kind of preliminary look at those. Okay, next slide, thanks. So now the patient characteristics. So we wanted to, I guess when the study started, again, the focus was really on, how much pharmacists are supporting patients in receiving access to medications, especially with the challenges in accessing primary care, which have only increased over time. So we wanted to know if there were any specific characteristics of patients that told us more about who was accessing prescribing by pharmacists more often and who maybe didn't have access to prescribing. There's some literature around income and whether there might be issues in using those services based on the fees that might be associated with prescribing. So as an overall look, what we found was that over 372,000 patients received a prescription by a pharmacist at least once over the study period. So that's who's included in the sample. And this gives the overall picture of what's happening. So I have the means and standard deviations presented here. So what we're looking at is in the top left there. So basically, patients that had more comorbidities, so those long-term chronic conditions, received more prescribing by a pharmacist. So those with 2 or more comorbidities had almost double the average number of prescriptions by a pharmacist. And then those in rural areas also received more prescribing by pharmacists. So again, the mean and standard deviation there. More females than males use prescribing. So this is interesting. So the N is the sample size. So you can see there's quite a few more females using that service. But on average, males are receiving more prescriptions per person than females. And then in terms of income, we were able to look at income based on census data. So it's not a perfect indication of the income of each individual person, but based on the area in which they live, we're able to get kind of a sense of what things look like in that area. So Q1 refers to the lowest income quintile and Q5 refers to the highest. So you can see that those in lower income quintiles actually received more prescribing on average than those in higher income quintiles. We also found that patients who were older received more prescriptions on average, and patients with certain drug plans. So again, another piece that we don't have perfect data on, but we're able to understand whether a patient may have access to a public drug plan during the study period. And individuals who had seniors pharmacare without copay received more prescriptions on average than those with other types of drug plans or no public drug plan. So I just highlighted a few of these in the slide, but we have a few more categories, which I'll show you next, that kind of lay out what this might look like. But it's not a perfect indication, again, of that public coverage, but it gives us an idea of what might be happening. So you can see here that factors to the right of that 1 indicate things that are associated with more prescribing. So the more to the right that little box is, and the bigger the box is, which isn't super clear on a slide deck, it means that's kind of a larger effect. So it's related to more prescribing by pharmacists. So you can see a lot of factors are close together. So age, continuity of care, we can see sex there. So we have males who are, again, receiving more prescriptions on average compared to females. We have those in urban areas receiving fewer prescriptions on average than rural areas. And then you can see the income quintiles there. You see how the boxes get kind of closer or more to the negative part of that, or closer to 0 as you get into higher income quintiles, meaning they're receiving fewer prescriptions on average. Comorbidities goes in the opposite direction. So those with more comorbidities receiving more prescribing by pharmacists. And then for the drug plan variables, it's kind of all over the place. And we had a really hard time figuring out what each of these are, what they mean, and how much their medications might be covered based on being on one of these plans. So it's not super clear-cut data, but again, you can see there that those kind of those groups with no copay, so the seniors pharmacare no copay, the income assistance no copay, receive more prescribing than those with no listed drug plan. Okay, I think I've covered that one. Next slide, Jen. So some key findings. So again, I kind of started to hint at these as I went through, so you could get a sense of how the two studies aligned. So both of the studies show that pharmacist prescribing was increasing over time. So more prescribing after COVID, certainly with the self-report, but also over time from 2017 to 2020 in the administrative data. Some of the kind of barriers and enablers found that pharmacists were really positive about their skills and knowledge, so really confident in their prescribing knowledge and the skills to do so. but felt under pressure in the pharmacy environment. So, with the TDF and those questions that we asked, we get a sense of that. But really, the qualitative data really highlighted some of the pressures that pharmacists do face in being able to have that one-on-one time with patients and having the time to assess and prescribe based on what's happening with the patient. Some of the demographic information shows us a little bit more about those who use prescribing more often. So again, it's a lot of this research is new around who is using prescribing and who might use it more, because the scope of practice of pharmacists has changed over time. But in Canada, if you've kept up with the news and you're seeing what's happening in other provinces, it continues to change. So it's really important to understand who might be getting access to these services and who might not be, based on issues around equity and equitable access to those services that might come with a price tag. So it showed a little bit more about those who might have unmet needs and accessing timely care from another primary care provider. So I think the rural piece is really highlighted in this data, and an important one as well when we look at access to primary care in Nova Scotia. And it also highlights what we need to do next, like every research, but we really need to better understand patient experience. So this presented one side of the story in terms of what's happening, how much prescribing is happening, and what the pharmacy environment looks like. But we don't know a lot about patients' experience with prescribing and changes based on pressures from COVID-19. So really it would be a great area of future research. And we just wanted to talk about knowledge translation a little bit and our approach to this work, because we started and we dug right into the research, but we didn't really talk about too much about where this came from or who this study was supported by. So Jen mentioned that this is an MSSU priority project. So one piece of this is that we take an integrated knowledge translation approach to our research. So the research question was identified through a collaborative process and working with stakeholders, patient partners, and government leaders that work in this area. So we had representatives from the Department of Health and Wellness involved in coming up with the question and then being part of the research team throughout the process. We also had one patient partner on the study who was involved, I think, again, from the very first time it was discussed right through to the end of the study. And that person played kind of varying roles through the two pieces of the study, but was able to give guidance and feedback throughout the process as well. We also worked with the team to develop a KT plan to try to disseminate the study to as many kind of audiences as we could. As everyone knows, this is a really hard part at the end of a study. We like to publish things and then just kind of jump into the next thing. So we're really trying to focus on making sure we get different messages out to different groups and creating products that would have good uptake with those groups as well. So our objectives really were to look at the prevalence of pharmacist prescribing, changes in prescribing since 2014. So that first study that was mentioned based on the TDF that Jen discussed. And then we were able to, again, pivot and look at changes during COVID-19 as well. And look at these local barriers and facilitators to prescribing. So, as, again, recent changes announced around pharmacist prescribing in the province, pharmacists are being able to do more and more, but this also comes with challenges. And there's definitely a need to better understand what those challenges are, both from a policy and then from a research perspective as well. So yeah, we have what we've gained, I guess, through the study is really baseline data. So when the study started in 2018, we didn't necessarily expect everything to happen that did happen. So the research was important then, but as primary care issue became more of an issue in Nova Scotia, it's even more important now. So we have this really good baseline data to look at what pharmacist prescribing looked like before the pandemic, before all of these additional policy changes took place. And then now we're able to kind of have the structure to look at that change over time as well. And then we're able to look at some policies and practices related to pharmacist prescribing and look at that change over time. So in terms of, if you want to know more about the project, so we have this, what is, more or less a quick presentation. We have the two manuscripts that we discussed, and we also have more information, and everything that's produced based on our KT plan is advertised or on our MSSU website. So it lists our contact information, a little bit more about the project, and then links out to those materials. So if you're ever looking for anything that's MSSU related, you should be able to find it on our website. And I think the last thing is references, which is the most boring slide, but important to acknowledge all the previous work and some of the information that we cited in the earlier part of the presentation. So yeah, I think that's it for me, which is great because I need a drink of water, but I'll let someone take over for a second.
Oh, what a fantastic presentation. Thank you so much to both of you. Really, I know I have lots of thoughts for questions, but I'm going to open it up to the participants to see if they have any questions for you. Well, while they're waiting and thinking, I have a couple, but I'll start with one and then hopefully it'll generate some others just to pop their hands up there. So one I thought was really interesting about the variation between males and females, because when I think about the top three being contraceptives, primarily for birth control for women, and then seeing males at higher, I was just a bit surprised. And so a couple of thoughts went through my mind about why that might be, whether it's just perhaps lack of sort of contact with healthcare providers and need for prescriptions that, or lack of provider, but I don't know. Did you have any insight as to why you saw those differences?
Who wants to take the question? Do you want to jump in, Jen, or do you want me to? You're going with the right slide.
I can start. I think you can
Sure.
see the slide now, right? I just wanted
Yep.
to bring that slide up. So our total numbers were higher for females than males. So like we had a large group of women who received them. What threw us was that men that did receive prescriptions received more. So I think it's still like it's a great question because for contraceptives, you would normally, like if it was birth control, you would have several prescriptions a year. So in part, I wonder if it's related to the timing of our data, because contraceptive management had become a funded service as of January of 2020, and our data went to March of 2020. So we may not have captured follow-up prescriptions yet. And that's a great thought going forward too with follow-up studies that we're working on as well, because this is something we're really intrigued by too. And in the literature, it's like women tend to seek, and well, in our data, it's from, as Amy said, it's what was housed in Health Data Nova Scotia, so it only identified sex. And so we have been trying to determine, like if we look at literature, it has about gender role, like a gender as a social identity factor, and women or people who identify as women using more healthcare services than men. So this threw us off a bit when we initially saw that those that were identified as male sex within the database were getting more prescriptions. But again, when we look at the numbers, we still had a lot of those that were identified as female sex receiving prescriptions, but just males received more. So I expect with the birth control part, it's a timing, or the contraceptive management was a timing of when the funding started and when that like when our data was captured. But it still highlights an area that we were all very intrigued by based on our previous knowledge of the literature and normal health seeking behaviors. So this was an interesting one for our whole team to spend some time on. Amy, did you have other thoughts?
Yeah, no, it's a great question, and why I love presenting, because every time you present, someone has a question that you didn't quite think about in the same way. So we did talk about that a little bit, and we do suspect that it's perhaps that males are trying to access a primary care provider but can't get in. So it's kind of like acute care issues that they then jump over to a pharmacy to receive that care more quickly. But we didn't actually look at the difference in the types of medications that males and females are receiving. So I mean, that could be a great follow-up piece that we could look at that, because yeah, it's a really interesting point to look at the volume of prescriptions for cystitis and contraceptives, and then to think about this finding as well. So yeah, good question, and don't fully have an answer, but we're just kind of guessing around why that might be that Jen spoke about.
Great. Thank you so much, Duana.
Hi, and just further to that, and I apologize if I did miss it. I wasn't sure if there was correlation of age compared to reported gender, like younger females getting simpler, encounters, the medications, numbers and types versus, say, older males.
Yeah, also a great question. And we didn't look at any interactions in the administrative data, which we have this kind of patient characteristics information on. But we have the sample size that we could kind of try to piece those out a bit and try to understand that more. So also a great point around age, sex, comorbidities. We could look those together and see what might be happening.
Great. Any other questions from the audience? Well, while people are thinking, just raise your hands and we'll hear from you, but I'll just ask one more, and then people can just think about other questions. So of course, probably should in some ways leave this to the end, but just you've acknowledged that it's just exploded with the increased scope of all health, allied health, nursing, pharmacy, all other healthcare providers. And just wondering if you have plans to do this again, because not just in what they're doing, but also when I think about the combinations of maintaining immunizations and vaccines, which is going to just continue, and don't see that stopping anytime soon. And the burdens plus the extra prescribing, just maybe three questions. One, about the study and moving forward, but two, what elements other things you might add in that questioning around, I know you've already talked about workload and burden, but specifically, what would the needs be for people to actually sustain that, and whether there's any impact back to the university around training new pharmacists, and also, I have all these things, but are there people on your team who would be in government, I would think, who are actually making those decisions and sort of rapid response?
All right, that's a lot of great questions. I tried to jot them down, so I may have to ask, or I may ask for some more clarification. So moving forward, this project is going forward as part of the puppy study being led by Dr. Emily Marshall. So I'm a co-PI on that study, and Amy's an investigator as well. So that was one of the rapid COVID-19 grants through CIHR. So we are looking at primary care access. And so we are running more of the HDNS data from the March 2020 forward, but we're also looking at for other providers, so family physicians and nurse practitioners. And we're also looking to see if there was a shift in the prescribing. So was it shifting from other providers to pharmacists during the pandemic, or was this just additional prescribing need? Because that's something we're not really sure, right? Is it that there's additional needs that were not being met at all, or is it a shifting need because a person can't access a family physician and they need to go somewhere else, so they're going to other providers like pharmacists or nurses? So there's a lot of things we're looking at with respect to that. The workload and burdens. So this is huge, that we're hearing in all healthcare providers with burnout and resilience and everything that's going on with everything being taken on. And we have heard, of course, the recent news announcements about the pharmacy primary care clinics, where pharmacists are offering additional funded services. So there's the pilot projects. They were announced at the end of January, and they just started with an additional site coming on, I think later this week or next week, maybe. So there's 12 sites across the province. And they're just part of the pharmacy, but it's a pharmacist who's dedicated to just doing clinical services by appointment outside of the dispensary flow. So we're going to see more about that too with that pilot project. So that's partnered with the Government and Pharmacy Association. And there's some projects that the Nova Scotia College of Pharmacists are involved with that as well. I'm not sure where we're going to see that go and what our work is going to be, because there is some assessment being done through the Pharmacy Association and the government with that. But that is certainly something that we've been thinking about a lot as well for follow-up, and thinking about the workflow and how that's going to be sustainable. And with training, similar, if we're training everyone to full scope of practice and they're more confident and comfortable and faster providing services, I guess that's part of it, as well as thinking of our new curriculum. So this is a DAL thing with our increased experiential education component. So a year of that within the pharmacy program, undergraduate program. There will be more advanced pharmacy students out in practice. So they might be able to offer more assistance as well. Like they'll have the opportunity to practice to full scope during their 4th year on those placements and things. So that can be beneficial for everyone, our students and the practices and government. And I'm probably missing all kinds of things, and Amy's probably going to be like, need to add more things. But the government, so we do have government representation. So we started with one individual who retired and somebody else came on board, but we've also presented for NSH and DHW, I think. Amy, we've done a lot of presentations, so we are trying to share, but they've had access to the data throughout too, and updates. They've been receiving updates, but we have done presentations for larger groups, and there is a lot of interest in this going forward as well. So now I'm going to hand it to Amy to fill in all the parts I missed.
No, you didn't miss anything, because I jotted them all down as well, because anytime there's more than one part of a question, it's hard to remember it all by the time you get to the end. But the only thing I can add around the government pieces is that some of our analysis were questions that they asked that we didn't necessarily publish, but we did provide additional data to them based on the analysis that we did, focusing on things like drug shortages and how prescribing for those changed before and after a shortage, common and minor ailments, which is something that's, again, being looked at in different provinces. So government likes to share within government, but no one always, not everyone sees that data. So we were able to share that information with them as well, as they were kind of in discussions with other provinces around common and minor ailment prescribing. So just to look at like what's happening here and what services are being used most frequently. So yeah, we were able to work with them throughout the process, and then kind of tailor our analysis and share that with them as we finish the study. So that's the only thing I can add, but you covered everything else. Yeah.
Well,
Thank you for the excellent questions. They're excellent questions.
I apologize for the multi-question. I just got carried away. There's just so many things. Now, is there anyone from the audience who has some questions, thoughts? Keisha.
Hello. Thank you. That was a very informative presentation. And my question, it might actually be beyond the scope of your project, but I'm very curious. So with the recent announcements around the expansions of scope, I have heard about a bit of pushback from various health provider communities. And so I'm wondering, maybe this ties into the barriers aspect, but I'm very curious around perceptions of the prescribing as well, because I know it can be territorial at times, and there are concerns around prescribers. So yeah, if you could speak to that a little bit.
That's a fantastic question. Thank you. And we heard a lot, especially recently with Ontario pharmacists having their scope expanded to common and minor ailments as well. That seemed to be the biggest uproar lately with that Ontario group. In Nova Scotia, because the prescribing started in 2011, we saw more of that then. I don't have our 2014 study right here to compare the actual numbers for the TDF because it's a great question. I know we did skim through. That didn't come up as much as a barrier, and Amy can let me know from the analysis piece on some of the stats on that. But that one didn't come up the same way it did in the past. And I think it's because it's been part of scope for so long in Nova Scotia that more people are just feeling comfortable and confident. We do still hear about some pushback from individuals from other professions who express concern, but not the same uproar we initially heard back in 2011 with prescribing when it was first announced, or in 2013 when immunizing first started with pharmacists as well. Those were the times that we really saw a lot, and I was doing work in both areas at the time too. So it was a lot of trying to explain, no, it's very like specific and it's very focused in the areas that, pharmacists can practice within and are very well trained to do these things. It's not, they're not going to diagnose diabetes or something, right? The same with what you're seeing with nursing now too, right? With the registered nurses prescribing, it's a very focused, specific training and things like that. So we just I think we keep seeing whenever, as you said, when there's new people coming in, allied healthcare coming in and doing more things, there's sometimes that pushback. Sorry, that's was a long answer, but we haven't seen it the same way this time around as we did in 2011 and 2013 when these were newer. I haven't done any evaluation yet with the new expansion with these primary care clinics or anything, but we're hearing very positive feedback anecdotally from the public. Well, just from reports from PANS and Nova Scotia Health. The public is very happy with these primary care clinics that pharmacists are running, and the ones that were partnered. I think it's with Lawton's, Amy. The original ones with the nurse practitioners, and those ones have been very positively rated as well. So we're hearing a lot of positive from that, and not quite the same pushback as Ontario is currently getting for their common and minor ailments. But we might see a change as these primary care clinics are doing more. But part of it feels like because we're so short of primary health care providers right now, or the access isn't there, that I don't know that people are as quite upset because they don't have time to take extra on themselves.
No, that sounds perfect and provides insight because I'm currently based in Toronto, so that's why,
Okay.
it's
yes.
yes.
Oh, yes. So you're hearing everything. So my colleagues in Ontario were just like, they're in the news constantly, like the pharmacy colleagues trying to explain what it actually means. And, like it's the kinds of things, of course, that an individual can go self-diagnose themselves, like minor and common ailments really just mean, you have heartburn, you go get, an antacid or something, but a pharmacist can help you do a further assessment and maybe choose something more tailored. So there, there's things like that. So yeah, no, Ontario is definitely lots going on right now that I feel like we've settled through some of that, but we might see more changes again as scope, continues to change and potentially expand. We might run into that again as well. Was there anything else I missed there? Sorry, I get excited sometimes when I'm talking about this. Amy, did I miss anything that you can think of there either? Okay, thank you.
Such a fabulous and such timely, I think, topic. And really, this information is so important for everyone moving forward, making healthcare decisions and trying to meet the needs. Oh, I see, Duana. Do you want to have a question?
I do. I have a quick one, and sorry if I'm taking away time from anybody else, but excuse me, in my work with Nova Scotia Health, I support nurse practitioners all over the province, including partnering with pharmacists. And I was quite taken to see the role that positive reinforcement and things has in this. And I just wondered, do you have, with your intricate knowledge of the findings and things, do you have any key learnings or anything that you want to stress in terms of how nurse practitioners can support, or anything else to offer as, like you say, the scope expands and that sort of thing.
That's a fantastic question. Thank you. I can't think of anything specific in the data that was about nurse practitioners specifically, but it was certainly like other primary care providers in general. We generally just asked in general about other providers, and I might also be linking to a little bit of our puppy study as well, where we've done some qualitative interviews as well. But certainly whenever it feels like there is that partnership with the other primary care providers, there's certainly that greater level of confidence to provide the care. And knowing that they can refer or speak to the other provider when it goes beyond. So even just having those partnerships where it might not be the patient of that provider, but that they have that consultation capability, which we're seeing with those Lawton's clinics with the nurse practitioners, those certainly have improved how the pharmacists are feeling about practicing to scope, knowing that when the assessment piece, because that tends to be the physical assessment piece that they have more limited training on, but they know they can refer and talk to their colleagues. So again, that comes from some of my other projects more than this project specifically, but certainly that social influences piece was huge. So having colleagues, other providers, people in their workplace specifically, or just a circle of people that they can consult with. Because pharmacists and community tend to feel often very isolated and siloed because you're in a pharmacy, not in a big hospital or part of a network or a big clinic necessarily. So feeling that they have that network of people they can talk to is certainly improves. Like there was definitely an association there within various projects we've done. So thank you for bringing that up. It's been certainly huge. And I think this reinforces our whole interprofessional, like we need that more because that helps everyone, especially the patients.
Exactly. Thank you so much. That will mean a lot to people who hear that. Thank you.
That's great. Thank you. Thanks for the great question.
Well, unless there's any other burning questions, I think that's a wonderful way to end our session today. Again, we'll look forward to the results of your other ongoing studies and any new studies. We would love to have you come back and share them with us. And just really thank you both for taking the time and for all of your wonderful work.
Thank you very much for having us and for the